In this lecture we'll start discussing with conditions that are having a short PR interval. So the PR interval, it is inversely proportional to heart rate. That means if the heart rate will increase, then the PR interval will reduce. So there are two conditions that we have a short PR interval. It is Wolff-Parkinson-White syndrome and Lon-Ganong-Levine syndrome. So don't get scared by hearing the name, they're extremely easy. So both these conditions, they have a accessory pathway of conduction present. So this is the normal conduction pathway where the impulse generates from SA node, then goes to AV node, then goes to right bundle and left bundle. But in these two conditions, there is an accessory pathway. That means there is an extra pathway other than the normal pathway. That is why they are having an increased heart rate and a short PR interval. So first we'll try to understand the WPW syndrome, Wolff-Parkinson-White syndrome. So in this syndrome you have an increased heart rate. This patient will have frequent palpitations due to this increased heart rate. So there is a extra pathway and this is called as bundle of Kent. So if this is the SA node, impulse goes to AV node and then via right and left bundle branches. So in this condition there is an extra pathway that this patient has, and this extra pathway is known as the bundle of Kent. Now you know that understand this as this is a railway pathway. This is the old railway track, but now with the invention of new trains they have made a new track. So this new track will be faster. That's why through this bundle of Kent the impulse goes faster, and that's why the heart rate is faster. So we have a faster conduction via the bundle of Kent because the impulse is not passing via the bundle branches. So it will not pass through the bundle branches. So that is why we will not see Q wave. So now if you go back to this circuit, the impulse is directly passing via the bundle of Kent. It is not going through these bundle branches. That's why you will not get Q wave. So due to this, the R wave, it has a change in slope and it is like a upswing, which is known as a delta wave. And in this condition the QRS complex, it becomes broader. So here you see there is a PR interval short and there is an upswing that is seen, and this upswing is called as a delta wave, which you see in Wolff-Parkinson-White syndrome. So if you want to know the normal PR interval, it is around 0.12 to 0.20 seconds, and a normal QRS interval, it is up to 0.08 to 0.10 second. So in this Wolff-Parkinson-White syndrome, PR interval will be short, the QRS will become broad, and very characteristically you will see the delta wave. Once you have understood this, we will go to the next syndrome, that is the Lon-Ganong-Levine syndrome, LGL. So the alternate pathway that is present in this syndrome is known as the James bundle. So from the SA node, the current will directly reach the bundle of his and it will miss the AV node. So now current from SA node will directly go to the bundle of his via the aberrant pathway, that is the James bundle, and it will miss the AV node. So now with the invention of a new train, they have missed the small station, so they have gone directly to the bundle of his. So because of this, there will be a reduced PR interval. The QRS complex, though, it will remain normal. So QRS complex was broad in WPW syndrome, but here QRS complex will be normal, and you will usually see a normal sinus rhythm in this case. So what is the meaning of normal sinus rhythm? That is, you will see a P wave, you will see a Q, R, S, and you will see T. Whereas in WPW you are not seeing the Q. So when a rhythm has this P, Q, R, S, T, it is called normal sinus rhythm. So these are the two conditions having a short PR interval. Now we'll talk regarding conditions that have a narrow QRS complex. So these are the conditions that are given an umbrella term called as supraventricular tachyarrhythmia. So what is the meaning of supraventricular? That means it is coming from above ventricle, and what is present above ventricle? It is the atria and the AV node. So that is the origin of this tachyarrhythmia. Tachy, it means rapid, and arrhythmia, it is the irregular. Okay, it is irregular. So this supraventricular tachyarrhythmia, it may be physiological or it may be pathological. So physiological we'll talk first, that is the physiological sinus tachycardia. So this usually physiological sinus tachycardia, it occurs because of a sympathetic stimulation and a vagal withdrawal which is seen during exercise, and if some kind of illness or during stress. That's why routinely, if you must have seen in your internship in casualty, if you have posted that many normal patients are having this sinus tachycardia. So what is sinus? That is normal, P wave, Q, R, S and T, and it's a tachycardia because if you calculate the heart rate, there is almost 2.5 square, so it is a tachycardia. Heart rate is above 100 if you calculate by dividing 300 dividing by the number of large square. Otherwise you're not having any other abnormality here, so hence it is a sinus tachycardia that can be seen in exercise, illness or some kind of stress. So that you have to keep in mind when you're discussing the narrow QRS complex. Then we'll talk regarding something that is called as a PSVT, known as a paroxysmal supraventricular tachycardia. So here there is a onset which is sudden, and also the termination is sudden. That's why the name paroxysmal is given. So this is an example of a narrow QRS complex tachycardia. So narrow QRS complex tachycardia, think of PSVT, paroxysmal supraventricular tachycardia, if it has the other features along with it. So if you see the EEG in your screen, you can see the QRS complex is very narrow here. Normal QRS complex is around 0.08 to 0.10 second. That is around 2 small squares, 2.5 small square. But here you can see there's only one small square. So definitely you on your ECG that is seen on your screen. You have a normal QRS complex. Along with that, if you see, there is a kind of a ST depression. Otherwise, normally, it should have come little up here, but here there is a ST depression that you can see. So in PSVT, you see a ST depression. Now I just like to make one point here that out of all the leads of ECG, in the lead AVR you get all reciprocal changes. That means everything is upside down, is opposite in AVR. So that's why in PSVT in AVR you will see a ST elevation. And just for theory, remember that in lead AVR everything you see reciprocal, that is opposite. Now why, we'll go that later in detail, but just for now remember, in AVR you see all reciprocal changes, everything will be opposite. And another feature important of PSVT is that you will see a merged P and T wave. Now see, this is P, Q, R, S, T. Then where P went. So because of this tachycardia, the P and T wave, they will become merged. So you cannot differentiate P and T wave. So there is a merged P and T wave. So that was about paroxysmal supraventricular tachycardia. Now we'll talk something regarding a multifocal atrial tachycardia. The next thing is called as a multifocal atrial tachycardia. Now see, if the examiner wants to ask something very difficult from ECG, then they'll ask you such question. Otherwise, the previous two lectures will cover your ECG. So if you're getting confused on understanding, it's fine, you can leave this. So multifocal atrial tachycardia, there will again be a variable RR interval. So first we'll note down the points, then we'll try to see in the ECG. You will have a variable RR interval. When you see a variable RR interval, you will think of atrial fibrillation, but I'll give you the next point which will take away atrial fibrillation out of the diagnosis. In multifocal atrial tachycardia, you will have a P wave that is present, and this P wave is having a variable morphology. Morphology is variable. So what is the meaning of variable morphology? That means first try to understand it is a variable RR interval. Okay, you're 2, you're 2.5, so that is confirmed. Then once you see variable RR interval, you try to find P wave. Now P wave is not very prominent, but you can just see there is a variable, means little bit of P wave is seen. So when you see little bit of P wave and irregular RR interval, then go for multifocal atrial tachycardia. The next diagnosis that is on your screen is called as a atrial flutter. First we'll talk regarding the most characteristic feature of atrial flutter, which is known as a sawtooth appearance that is seen in atrial flutter. So why is atrial flutter caused? It is caused because of a abnormal electrical circuit which is present in the atria, and that will make the atria beat quickly and will cause it to flutter instead of squeezing. So instead of the atria which is supposed to be squeezed out properly, it will flutter. In Hindi this is na fat karega, like a bird, it will flutter, and that gives a sawtooth appearance. So this is what we explained you in our words, but in the textbook something is written like this. There is a macro reentrant circuit around cavo-tricuspid isthmus. So there is an extra circuit around cavo-tricuspid isthmus in the right side of heart. If you remember, atrial fibrillation was having multiple ectopic foci in left atrium, but here in atrial flutter you are having macro reentrant circuit around the cavo-tricuspid isthmus. Now this cavo-tricuspid isthmus, it is present between inferior vena cava and the tricuspid valve. So the meaning is the same thing that we wrote in white. So just if in case in the MCQ you come across such terms like macro reentrant circuit around cavo-tricuspid isthmus, then think of a atrial flutter. And as we discussed, Now we finished discussing narrow QRS. If you see a wide QRS complex and there is tachycardia in the ECG, then in the MCQ just go for the answer as ventricular tachycardia, whereas paroxysmal supraventricular tachycardia was having a narrow QRS complex, whereas a broad or a wide QRS tachycardia go for ventricular tachycardia as the answer. Thank you and do revise.